Okay, it looks like it's top of the hour. Thank you everyone for joining us today for our webinar. Just a couple quick things before we get started. You can submit questions in the questions panel throughout the webinar, and we'll try to get to those at the end. And your certificates, if you join us for the complete webinar today, will be available on Friday by logging into your account. Taryn and Dr. Spatz, if you're ready to get started, go right ahead.
Great. See if we can move this along. All right, thank you guys so much for joining Dr. Spatz and I today. We are going to be talking about transitioning vulnerable infants to breastfeeding prior to discharge. Our disclosures: I'm currently a member of the Clinical and Scientific Advisory Board for Medela Americas, and Diane serves as the chair of the Clinical and Scientific Advisory Board for Medela Americas. Our objectives that were listed on the website are here to remind you. We're going to be talking about the transition to breast pathway, the 5 interventions that make up the transition to breast pathway, and then utilizing that current data and breastfeeding rates to facilitate ongoing quality improvement in vulnerable populations. So for us in the ICU setting, the pictures that are on the left-hand side isn't an unfamiliar scene. We see babies that are very sick. And so I had a question when I was a bedside nurse of how do we get from this very critical and vulnerable state to a breastfeeding state. Before we get into the pathway, Diane is going to talk about some background information and how we as neonatal providers can achieve this as the ultimate goal. So Diane is up.
Thanks, Taryn. So all of you are very familiar with the Baby Friendly Hospital Initiative. And, you know, it's really pretty interesting to consider that the BFHI has been around for over 25 years. Yet it only kind of gained momentum in the United States in about the past decade. And that was really because the federal government, the Centers for Disease Control and Prevention, incentivized hospitals to go through the process of becoming baby friendly. But a major gap in the Baby Friendly Hospital Initiative is that it really doesn't focus on the needs of vulnerable infants, those infants that are separated from their parents. And this is really a missed opportunity in the Baby Friendly Initiative. I've worked with many hospitals in the United States and around the world who've held the baby friendly designation, but when you looked at their human milk rates at discharge for vulnerable infants, they were extremely low. And even with my students that I teach at Penn, I would have them ask me questions such as, Dr. Spatz, I'm having clinical at a baby friendly hospital, but they don't have donor milk in their NICU. How is that possible? So we really have to have a different model of thinking about vulnerable infants than the traditional BFHI. Next slide, please. So when I was recruited to Children's Hospital of Philadelphia in 2001, I had come from working on a National Institutes of Health research grant. And in that research grant, we used master's prepared advanced practice nurses to improve human milk and breastfeeding rates. And coming to Children's Hospital of Philadelphia, I knew that if I tried to apply the principles of Baby Friendly Hospital Initiative to that setting, no one would have any buy-in. It would not be effective because the needs of vulnerable infants are significantly different than those of healthy infants. As you know, our vulnerable infants cannot go directly to breast at birth, and even sometimes skin to skin has to be delayed due to the critical nature of the child. And so I knew that we needed a completely different model if we wanted to achieve breastfeeding outcomes similar to term babies. And so this article was published in 2004, almost 20 years ago. And we know that it works because we have evidence behind each of the steps and publications demonstrating its significant outcomes. Next slide, please, Taryn. So Taryn, when she looked at her project, was familiar with this model because all of our policies and procedures at Children's Hospital were kind of based and shaped around these 10 steps. What is very helpful to understand about the 10 steps is that they are stepwise and they're sequential. So for example, if you don't help people make informed feeding decisions, and we don't help them effectively establish and maintain a milk supply, we're never going to get to breastfeeding at discharge. So we have to invest in a step-by-step sequential fashion. So with Taryn, she looked at this and thought, how can I apply this and help this work for our surgical population? Go ahead, Taryn.
So at the time, I was the nursing chair for the NICU breastfeeding committee, and I had identified a problem that was going on within our level 4 NICU, that our infants were not transitioning to breastfeeding prior to discharge. And what was actually happening was the day of discharge, a mom would say, oh, can you page lactation? I want to try and breastfeed. In the midst of nursing, trying to teach them about safe sleep, shaken baby, how to administer the medications, how to place an NG tube, in a very stressful and overwhelming environment, the breastfeeding session didn't go well. And so I approached Dr. Spatz and said, is there a way that we can make this a priority within our unit? Because it's a huge problem. And so we applied for the Sigma Theta Tau International's Maternal Child Health Leadership Academy in 2008, with the plan to implement this QI project in the NICU to address this problem specifically. I'm going to stop here because I can't be the only person to have identified this problem. So we're going to have a quick poll to see if this is a current issue in your practice area.
We'll just give everybody another moment to vote, if that's all right.
Mm-hmm.
Okay, let's go ahead and see what the answer is.
Okay, it looks like 82% say yes and about 18% say no.
Not surprising, right? When we, especially in an intensive care unit, we're able to do the intensive care part real well. And then we forget about the normal baby stuff. And so I'm going to talk briefly and just give a little bit of history about the Maternal Child Health Leadership Academy. And then we're going to jump right into the transition to breast pathway and the data that was collected. So the Maternal Child Health Leadership Academy is a 5-day conference that's split into 2 separate days. One's a 3-day, one's a 2-day conference. And the overall objectives of the Academy is to improve maternal child health outcomes through leadership and shaping evidence-based practice. Also to influence maternal child health practices within a variety of settings. Create and effectively lead an interdisciplinary team to improve maternal child health care practice outcomes, and then disseminate those results in leadership development for maternal child health. What the Maternal Child Health Leadership Academy focused on throughout the whole process is Coos and Posner's Leadership Challenge. And what that is a 5-pillar leadership model that focuses on the following 5 pillars. The first one's model the way, which encourages leaders to behave the same way they encourage others to behave, with their own voice and their own values. Inspire a shared vision focuses on developing a vision and series of goals that everyone at the organization cares about and works towards collectively with clear understanding. Challenge the process encourages moving outside the boundaries to be innovative to make change. So the excuse of, well, this is the way that we've always done it, no longer applies. Enable others to act is the fourth pillar and is trust-based, encouraging leaders to create a safe and trusting environment for people to collaborate, experiment, and engage. And the last one, which is my absolute favorite, is encourage the heart, which is most uncommonly seen in leadership roles. And it focuses on developing a vision and a series of goals that everyone at the organization cares about and works towards collectively with clear understanding. So, what is Project Transition? During the time at the conference and through the Leadership Academy, we were able to create an executive summary, create objectives, and identify our goals and outcomes that we wanted to achieve over this 18-month process. And so Project Transition was to increase the number of surgical infants that transitioned to feeds at the breast through a continuous quality improvement project. Our objectives were to decrease the resistance to breastfeeding and for it to become the standard of care in the NICU. Our goals, which was said in the executive summary, was to increase the percentage of breastfeeding infants prior to discharge and to decrease the stress on the infant by transitioning to at-rest feeds through non-nutritive sucking. So first, we started with a survey to determine the staff knowledge about human milk and breastfeeding. And what do you think about the following quotes that are listed here? We need more education and increase in comfort, and we forget about it. And it's true, we forget about it. So that says to me that it's not a priority. And how do we change that culture within the unit? So Crico Lisa published an article regarding these exact same statements, that there are negative feelings towards breastfeeding and associating them with the lack of breastfeeding exposure, education, and unsuccessful breastfeeding experiences. Wow, right? And then Bernay reported that nurses' attitudes and opinions directly related to the success of breastfeeding. So this is a great time to do a little introspective check on your own implicit biases. Get rid of your own breastfeeding journey, your own pumping history, and really hone in on the fact that this is your duty as a nurse to be able to help these lactating parents achieve their breastfeeding goal if that is their goal. So we are the missing piece to the puzzle. So one of the questions that we asked in the survey is as follows. Do you think our patients do not transition to breast or attempt why do you think, that they don't transition to breast or attempt non-nutritive sucking prior to discharge? The yellow bar is the initial survey and the black bar is the resurvey. And I want to just point out a couple of things. So we forget about it. One of the biggest statements here, 24% said don't have enough breastfeeding support and that it's not our priority and it's not our cultural norm, so we just automatically, we forget about it. When we resurveyed at about 6 months, we saw that drop to 7%. And then the lack of education was about 35%. And so that was a big one. And we're like, okay, both Diane and I were like, we can handle the education, we're on it. And then when we resurveyed, again, it was around 7%. And then ongoing throughout this whole 18-month process was time. And time continues to be a major factor, regardless of what level NICU you work in across the country. So since education was needed, we provided that by an initial team meeting that was prior to the start of the project, and then a second team meeting that was held after 6 months with resurvey and re-education of the nurses. We used PowerPoint presentations to explain the data, our collection form, how to utilize the form, and that it was important that that data then got back to me so that I could enter the data. And then we have in the Children's Hospital of Philadelphia, our unit is split up into different units, and we have different core teams. And I predominantly had worked on the surgical core team as a bedside nurse. And so my focus was specifically on the surgical population. Those are the babies that, if we're going to be honest, don't eat for a really long time. And so they're the most vulnerable when it comes to lactation failure, as well as not transitioning to at-breast feeds. And so we explained the transition to breast pathway, which we're going to get into. Re-educated along critical points within that 18-month period. And then we had the nurses that were our core members of the team that would train the trainer model, train the other nurses along the way. So all of this was prep before we even started the project. And so there are 5 interventions that create and make up the transition to breast pathway. And we're going to talk about each of these individually. The first and the most important is the initiation and maintenance of milk supply, mouth care with human milk, skin to skin care, non-nutritive sucking at the breast, and then ultimately breastfeeding. And like Diane had said, each of these builds on one another, and which is why I said the initiation and maintenance of milk supply is the most important, because if we don't do that in the very beginning, the goal at the end of the day to get to at-breast feeds is not going to happen. So how do we do that? Initiation and milk supply. Initiation and maintenance of milk supply. Within the first week, we want you to initiate pumping, ideally within 2 to 4 hours after birth, ideally 2 hours after a vaginal delivery, and 3 hours after a C-section. We encourage the lactating parent to pump every 2 to 3 hours with a goal of 8 pumps in 24 hours, and the use of colostrum bottles until the parents reach about 20 milliliters per breast. And as we know in the ICU setting, this is our cultural norm. Pumping is a staple, and we have to be able to be the first line, especially after hours or on the weekends when lactation may not be available, to be educated, to be able to support the lactating parent through this initial process. Our patients are initially too critical to breastfeed, right? Especially in the surgical infant. And so it is important that they have a double electric hospital grade pump that will mimic nursing, as well as an ongoing continual assessment and encouragement from nursing, the advanced practice provider, the neonatologist, to be able to come in, the lactation consultant, to be able to come in and say, you're doing a great job, keep doing everything that you're doing. The other important piece that we had started, and this was an ongoing practice prior to the project starting, was labeling the colostrum with orange dots, as well as numbering them so that the nurse would be able to recognize which bottles were colostrum, in which order they should be utilized in, as to prime the gut in prep for full feeds. The second week, when we're coming to volume and we're transitioning from colostrum over to mature milk, the ongoing assessment during this time is crucial. There is a goal of around 500 to 1,000 milliliters in a 24-hour period, and the use of the 80 ml collection bottles will be used at this time because we're transitioning over to that mature milk. And so as nurses, we tend to forget about this. But ultimately, at the end of the day, we should be the ones assessing the milk supply volume on a daily basis so that we can then trigger red alert, red flag saying, okay, this mom's struggling. I really need to call lactation to be able to come in to do whatever intervention needs to happen, as well as being able to be skilled in that area, especially nights, weekends, to be able to also help that mom in that critical period of time. The second intervention, which was new to practice and a big cultural change for us in our NICU, was the use of human milk for mouth care. So this is one of the state of the articles that was published in 2005 that goes over the importance of using human milk for mouth care. So in this article, it states that there are anti-inflammatory and pro-inflammatory cytokines in human milk that protect the vulnerable infant against infectious organisms. Well, that's pretty cool. Why aren't we doing this more? Is the question that I asked. And so in this article, it suggested that there's systemic absorption of those cytokines through the buccal cavity, which provides that systemic protection. One of my absolute favorites is pancreatic secretory trypsin inhibitor, PSTI for short, that was found in colostrum and then again later in mature milk. And why is that my favorite? Well, if you know anything about babies that are in the NICU, your majority of them are either premature or you have a surgical problem. And PSTI actually has been shown to have protective properties along the gastric mucosa, and it actually facilitates gastric repair of the mucosal lining if it's damaged. So I think that's amazing, especially in the population that we work in. So this was a crucial step, especially for the surgical infants who weren't going to eat for days to weeks to months. So this is what it looks like. And these are actual patients from our Project Transition project that we did with all of these pictures have consent that the parents have signed in order for us to use them in this presentation. And so the goal, the ultimate goal would be to have the lactating parent pump at the bedside, and then the use of a sterile cotton swab coats the infant lips and then inside the cheeks with the human milk, and to be done once a day at a minimum. But parents got really excited about this and they loved doing it, so much so it was done multiple times a day. So for parents that are initiating pumping, the fresh colostrum is brought to the NICU if they're not pumping at the bedside to start mouth care as soon as possible. That colostrum is then placed in the freezer for later use when feeds are initiated. Breast milk should never be pulled from the freezer and thawed just for the use of human milk with oral care. Step 3 of the transition to breast pathway was skin to skin care. And we know a lot about this, and there's been tons of presentations and tons of literature that's been published about skin to skin and the benefits. The trouble that we see often in the surgical population is that those children are usually too unstable to do skin to skin care immediately after birth. So this is a little boy, his name is Jeremy. He was very sick when he was born, had a CDH, was intubated, had all the things, the lines, the PICC line, the name it. And then after his repair and when he got extubated, a couple of hours after he got extubated, after we knew he was good and he was gonna fly, we transitioned right over into skin to skin with his mom. So again, this isn't usually the first thing that's on our minds as nurses and advanced practice providers, but it should be, because this ultimately is the next step that's going to build onto the next step, which is going to ultimately get us to the goal, which is breastfeeding. So benefits, again, abundance of research that's out there. For the lactating parent, we know it enhances the bonding, it increases the milk supply, enhances mood stability, decreases breast engorgement. There's actually 2 Cochrane databases that are related just to skin care, which is amazing. And then again, we know that all of the benefits for the infant. Tons of nursing research that's out there that has described these benefits for both term and preterm infants. And so I'm just going to point out a couple of these since the list is long. Improves oxygenation, rapid brain development, decreases length of stay, and then most importantly, earlier transition to breastfeeding. Another huge culture change within our unit was non-nutritive sucking at the breast. So this is a critical step as prep for transitioning to breastfeeding. And it would basically, the easiest way that we would describe this to families is we want you to practice breastfeeding before we're asking your baby to actually perform breastfeeding. So this is a great time for them to work on latching and sucking when they're not actually fully ready to do oral feeds at the breast. So the baby is placed onto the breast after a mother has fully pumped and emptied her breast. And in this case, this is Ruby. She was one of the patients for a few slides back where the father was doing mouth care with human milk. She was on ECMO. She was very sick for a very long time, bilateral chest tubes, the whole thing. And this is her actually performing non-nutritive. She is still on high flow nasal cannula here in this picture. And Holly, her mom, was able to really perfect the latch before we were asking for her to really perform. And it decreases the amount of stress on the baby and the parent during this time, especially when they're trying to actually breastfeed. And so once they're extubated and we feel that they are safe to actually attempt non-nutritive sucking, we went right to non-nutritive at the breast with the goal of doing that at least 1 time a day. And again, most importantly, the lactating parent has to empty the breast completely prior to doing this. And then the ultimate goal, step 5 of transition to breast pathway is transitioning to breast. And so we want the baby to be hemodynamically stable, meaning stable heart rate, no bradycardia, no tachypnea, no apnea, periodic breathing, and the ability to maintain their oxygenation throughout this period. At the Children's Hospital of Philadelphia, we rely on pre and post weights with the baby weight scale. Not every unit has that, but we relied on that in order to determine the success of the breastfeeding session. It allows to also determine how much the baby was able to transfer at the breast. And so we utilized those and then was able to supplement the remainder of the prescribed feed through the feeding tube if the baby had a feeding tube still. And so those are the interventions, and throughout that ongoing education, I felt like I lived at the hospital for those 18 months trying to really change the culture and push the needle forward. And so how did we do? So one of the survey of pre and post education, again, yes, is yellow, and then 6 months later, we reassessed, and the black again is no. And so the question was, are you comfortable with helping a mother breastfeed? In the initial survey, 76% said yes. At the resurvey, 93% said yes. So great, we're more comfortable in helping a mom breastfeed. So education and reinforcement made a huge difference in the comfort level of nursing. Another question was, are you comfortable with the transition to breast pathway? In the initial survey, 76% had said yes. And then the resurvey at 6 months, 100% said yes. So again, focusing on integrating the pathway into daily nursing practice really increased the comfort level throughout this process. And this is the data collection form. This was, back in 2008. So we weren't utilizing Epic for the ability to pull data from the electronic health record. And so all of this was done on paper and then manually entered by myself. And so we utilized this as a trigger at the bedside that not only parents could fill out, but nursing could also fill out. And it was in the order of which we thought would trigger the next step of the transition to breast pathway. And so you can see here initiation of pumping and maintenance of milk supply. Again, daily assessment, but from week to week, we wanted to know how many pumps was the lactating parent averaging and the daily milk volume. And then the goals were in the right-hand side column. The next, breast milk mouth care, the next, skin to skin. And each of those individual boxes, they were either put the date or put a check marks in the box. And then on the back side of the form was non-nutritive sucking at the breast, my first breastfeeding experience, which we all celebrated with streamers and balloons and lots of excitement. And then any subsequent breastfeeding attempts, date, time, and the amount transferred. And then this form would then be returned to me, placed in my mailbox. So what are the results? And so we had a total sample size of 80 participants, and any neonate that was admitted to the neosurgical nursing team in the NICU with complex surgical diagnosis requiring surgical intervention was included in the project. So looking at the first intervention, initiation of pumping and maintenance of supply, we had 100% initiation rate of pumping with the average milk supply of around 603 milliliters in a 24-hour period. Now, while all lactating parents initiated pumping, 11 had stopped during the time period that their child was admitted into the NICU. Some were related to being young of age, so we had a couple of teenage parents, social stressors, and or low milk supply that facilitated the decision to stop pumping. Was that low milk supply potentially related to inconsistency of pumping? Probably, and we didn't dive deep into that given that it wasn't a major focus of analyzing this part of the data, but it could definitely contribute to the decision to stop pumping. Mouth care with human milk. Overall, 71% of the infants that were enrolled in Project Transition had mouth care with human milk with a mean of 9 days. And I thought that both Diane and I thought this was a great, since this was one of the newest interventions and culture change within the unit. Skin to skin care. So again, a lot of factors go into whether a baby is stable enough to do skin to skin care. So 48% of the infants enrolled in Project Transition actually had this intervention performed, with a mean of about 6 days, median of around 4. And so because the data was positively skewed between the number of days, we looked at the gap between the mean and the median in this scenario. And then non-nutritive sucking at the breast. Another big difference of intervention for us and a culture change. 66% of the babies enrolled in Project Transition had this intervention performed. And so we really thought that this was a great intervention that ultimately led to the success of the project. And we thought 66% for a new intervention was wonderful. There were 8 infants that were unable to transition to breast due to the risk for aspiration. They were transferred out of the NICU, and so this was very specific to the NICU, and so it wasn't done on the different unit. And then there was also an infant that was withdrawn from support during this time. So the mean of 3 days and a median of 3 days also, so 3 days leading up to 3 days of practicing leading up to transitioning to at-breast feeds. And then ultimately transitioning to breast, the goal. So 100% of the remainder of these infants that were in Project Transition and transition to at-breast feeds prior to discharge, with an average of 8.8 days prior to discharge. How amazing is that, right? We're not waiting to like N-1 hour, here's safe sleep, here's how to give your meds, here to how to place an NG tube, and then BTW, lactation is coming in, we're gonna put the baby to breast, and then boop, you're out. No, we had 8.8 days leading up to a discharge on average that these babies transitioned to breast. And during that time, they had all of the resources in the world to ensure that outside of the hospital, they were going to be successful. And this is huge. This is huge for us in the NICU. So what did this do to our length of stay? And so our length of stay, this is me, I'm like a baby, not baby, I'm an experienced bedside nurse here with Amelia, and she was one of the babies that I took care of for a really long time. She was in the hospital for months. She had a long gap esophageal atresia and went home breastfeeding. And if you know anything about long gap esophageal atresias, the fact that she took anything by mouth was a huge success. So the average length of stay for our patients during the project was 43.7 days. This is the overall progress throughout the year of data collection. It wasn't a smooth road. As you can see, we have the blue line that represents mouth care with human milk. Red line is skin to skin care. Green is non-nutritive sucking at the breast. And then the purple line is transition to breast. And so it was important that ongoing re-education of nurses and encouraging each step of the pathway occurred throughout this whole period. This is some feedback from the staff. I'm not going to read all of these quotes. They're in your handoff. But the overall themes were that it enables nursing to work closely with parents, helps babies go home breastfeeding, encourages staff to promote breastfeeding. It's a reminder to assess the lactating parent's milk supply and progress through the pathway, encourages parents to be active in their baby's care, and makes staff more aware that the baby will solely be breastfed soon. What did the parents think? So this lactating parent was told that she would never be able to breastfeed her baby. And we made that happen. Her quote was as follows: "I think this is a wonderful program. When I was told that I may never breastfeed my little girl, I cried. I completely believe it is this program and their encouragement that she and I got to travel this path of natural bonding. Thank you to all that are involved." So not only did she get to breastfeed, but she transitioned to breast 7 days prior to discharge. It's huge. Another parent found our staff to be really supportive. Her quote was, "I have to commend and applaud the lactation department and the NICU nurses for their knowledge and support of breastfeeding. I appreciated both the nurses and the lactation consultants. They truly exceeded my expectations. They all knew that I wanted to breastfeed and supported me in my efforts." This is Vincenzo. He was a gastroschisis. That was also a hiatal hernia. He transitioned to breast 16 days prior to discharge. Absolutely amazing. And then one more example, in maintaining family-centered care environment, supporting our parental decisions, and creating this ideal patient-family experience. Going back to Jeremy, the CDH that was super sick doing skin to skin, his mom said, "I applaud all of your efforts in the efforts of the hospital to inform families and making it an environment where families are able to choose what they want for their child. Our decisions were always respected and supported." Jeremy transitioned to breast 7 days prior to discharge. So this work has been published in the Journal of Perinatal and Neonatal Nursing. You can find it here. And then I'm going to give it back to Diane, and she's going to talk about what has happened since Project Transition.
Thank you, Taryn. As Taryn was speaking, I actually got teared up a couple of times, and I actually got goosebumps a couple of times thinking about these families, right? And when I do my work, I always talk to people about the fact that when you have a baby, having a baby is a life-changing experience. No one's ever the same after they have a child. But then if you have a child who is born and is critically ill, your entire world can be shattered. And we as healthcare professionals owe it to our families to normalize whatever we can and help them in their journeys if their goal is to breastfeed their baby. I will tell you that I use the KP leadership model every day of my life. I was lucky enough to be faculty for the Maternal Child Health Leadership Academy for about a decade, and I use this in my clinical practice daily. A lot of times as healthcare providers, no one is encouraging our heart. We saw this all during the COVID pandemic. The parents who participated in Project Transition kept that piece of paper for their scrapbooks. They used it as a memento of their experience. And I think it's so important for us to really think about, we as healthcare providers don't own the baby, although oftentimes we feel like we do. We don't own the baby. We're not going home with that baby. So we have to do what we can to make sure that locus of control always gets shifted back to the parents. And that's really been a focus of my life's work. Next slide, Taryn. I have always had a particular affinity to babies who are critically ill. It's actually the reason I came to Children's Hospital of Philadelphia. Some of you know my work and have read my publications, but again, I think it's so important to think about giving back that locus of control to parents. So in our Center for Fetal Diagnosis and Treatment, we have a midwifery model of care. So even though our parents have critically ill babies and they're being followed with maternal fetal medicine, they also have access to midwives. So we developed a modified version of group prenatal care, which has been demonstrated to improve pregnancy and birth outcomes. And so as part of group prenatal care, when the families came together, in about groups of 5 to 7 families, they would learn about their pregnancies, birth, and their infants together. Part of that intervention was a session on lactation, where parents learned about the state of the science of human milk and how human milk could impact their, in particular, baby's outcomes, as well as the physiology of lactation. And it's very important to note that not all of our families come with prenatal intent to provide milk for their babies. Next slide, please. But what's really important is that once parents learn the science, once they learn about human milk, they want to do that for their child. I've had families come in dead set against providing milk to their baby. Our babies got formula, our other children got formula. Formula is just fine. And as soon as they learn the ways in which human milk impacts their child, everyone wants to sign up for it. So we have to help families learn that science. 100% of our families who participated in group prenatal care initiated pumping for their children. But what's more impressive, I think, than the initiation rate is the continuation rate. Because if you look at national data at discharge for sick babies, all right, it's maybe 50%. Some centers are even lower than that. And even if we look at data for healthy term babies, discharge human milk rates are lower than 87%, okay? So our parents not only made the decision to provide milk, but they kept doing it through very long hospital stays with their children, either in the neonatal intensive care unit or the cardiac intensive care unit. And for me, it has always been such an honor to be able to help and work with these families to help them have a better experience with this life-changing event. Next slide, please. Our newer publication from 2022 looked at families who had a personalized individual nutrition consult. We actually call it a nutrition consult, not a lactation consultant, because we want them to think about nutrition for their child. Some people have preconceived ideas that breastfeeding is not for them, or that it's gross, or that they don't want to put their baby to breast. We want to get beyond that. We want to, again, focus on that science of human milk and the physiology of lactation. So we modeled this research after the CDC data, where we looked at both initiation of breastfeeding and continuation through the first year of the child's life. We contacted the people, 3 methods. We did phone, text, and also email. And we had a very high response rate. Next slide, please. And what you can see is all of the outcomes at all time points at initiation, 3 months, 6 months, and 1 year are statistically significantly higher than the data reported by the CDC. We have an impressive over 50% of these families still breastfeeding, still providing milk to their children when they are 1 year of age. And we have 1/3 of them who are breastfeeding beyond a year. Again, this is of critical significance because all of this occurred before the AAP came out with their updated position statement saying we should breastfeed beyond a year and we should breastfeed for 2 years, okay? So these parents, once they had the knowledge and the science, were making it happen. Next slide, please. In the cardiac population, people have always questioned whether or not cardiac babies can breastfeed, should breastfeed, and if human milk is adequate. There was a webinar by Medela presented in July by one of my doctoral students who did her work in this space. But earlier, prior to her work, we also looked at this at Children's Hospital of Philadelphia. And there were 2 significant things that I'd like to point out. One is the families who gave birth with us had significantly higher initiation rates. So that means they were having the opportunity to make informed feeding decisions. The second thing is the babies had a high exposure to human milk. However, it was often not directly at the breast. And this is where Kristen's work picks up about the factors that contribute to direct breastfeeding in the cardiac population. Next slide, please. Another really interesting population is babies who have myelomeningocele. So at CHOP, they were the pioneer of doing fetal surgery on babies with spina bifida, right? So if you remember the MOM study, where babies were randomly assigned to either get in utero surgery for their MMC or post-utero surgery, Dr. Adzik found that babies had better outcomes when they had in utero surgery. But what makes this challenging for breastfeeding is that because they've had in utero surgery, they get delivered at 37 weeks gestation because there's a fear of uterine rupture. So when the babies are born, not only have they had fetal surgery, they're late preterm babies. And what do we know about late preterm babies and their breastfeeding behaviors? And so this first started as a quality improvement project, which we then transitioned to an IRB approved research study. And it actually was incentivized, or the reason we did it was because one of our surgical nurse practitioners stormed into my office one day and started yelling at me about the lack of assistance and support that MMC babies were getting. And she was like, this is just terrible. We should do better. This is just, what are you going to do about this? And one of the big things about these babies is for our particular unit, they were very healthy. They were very healthy because they usually came out and they didn't require intubation and they weren't critically ill. So people wanted to treat them like they were term babies and try to rush them out the door. And one of the things they did was they pumped them full of formula, even starting on day of life 0. So Taryn was part of a group who developed PO ad lib guidelines to prevent overfeeding of our healthier babies. So we looked at cohort 1, which is the baby before the development, the cohort of babies before the pathway. And then we looked at cohort 2, which was after we had that PO ad lib guidelines in place. Next slide, please. So the PO ad lib guidelines were really meant to support healthy breastfeeding, right? And so this is a struggle we know even in baby-friendly hospitals, that babies get overfed. They get supplemented, day of life 0, day of life 1, day of life 2. It's a real struggle for people who work in NICUs because they're like, oh my gosh, colostrum, it can never be enough. There's never going to be enough. The baby's going to starve, okay? So we wanted to make sure we gave these babies a chance to develop breastfeeding skills and feed at the breast and minimize the amount of supplementation that they were exposed to. Next slide. And as you can see by this graph, these babies who had myelomeningocele had a very, very high exposure to human milk, almost 100% initiation throughout the course of the project, even before implementation of the PO ad lib guidelines. But what you can see happen when we introduced the guidelines, the reduction of formula use was cut in half. So that was a really big win, okay, minimizing the exposure to formula to these babies. And then you can see it crept up just a tiny bit. But the other thing that occurred was prior to this intervention, no one ever thought of these babies as being candidates for donor milk. And these babies are sick babies, even though they're, quote, healthier for our nursery. So we had the option for these babies to get donor milk instead of formula. And in fact, after we completed this project, we began to consent for donor milk prior to birth, not ever as a replacement to parents' own milk, but as a potential bridge, which was positively received by our families. Next slide, please. And Taryn and I have both always had an extreme passion and love with our babies who have congenital diaphragmatic hernia. And some of you may might be thinking like, wow, why would you love those babies? Those babies are really sick. Those babies try to die. And the reason that I have such a love and an affinity for these children is that human milk is so important for them. It's important for their brains. It's important for their lungs. It's important from preventing them from getting infection. It is such a life-saving intervention for babies with congenital diaphragmatic hernias. So we looked at our babies who had CDH, and there was 149 babies, and this was done after we had EPIC, so this was done through chart review. And we looked where they were born, either in-house or outside, and if they had prenatal lactation visits. And as you can see, the majority were born at our institution, and 60% had prenatal intervention. I will say I was disappointed in this number. I was hoping that the number would be 100% that had prenatal intervention. But if the person transfers care late or there's no time in the schedule, people get missed. This is the reality of clinical care. But I think what's so important about this data is that for the people who had a prenatal consult, 100% initiated lactation. Go ahead, next slide. What is also significant is that the women who did not have prenatal intent changed their mind. Okay, so 10 women had no prenatal intent, and they changed their mind and they began pumping for their children. The milk supply of the people who had prenatal intent was slightly higher than the moms who did not. So again, thinking about what we do in clinical care in terms of prenatal counseling. Next slide, please. These babies had very long length of stays, okay, but they were able to primarily receive human milk through discharge, almost 80%, okay? And another common misconception is these babies will not grow exclusively just on human milk. And over half of our babies were discharged on unfortified milk. Next slide, please. So my model has also been implemented at other hospitals with significant increases in human milk at discharge. So this is an example from Tampa General. Next slide. This is an example from the Florida statewide implementation where we worked with the Florida Perinatal Quality Collaborative. Next slide. This is an example from my work in Thailand where human milk rates at discharge are also statistically significantly increased. Next slide. And then in Japan, where they only looked at the first 5 steps and had a substantial significant increase by just focusing on the first 5 steps. Next slide. Nellie was a DNP student in Minnesota who contacted me. She said, I've read all of your publications. I love your work. I would like you to help me with my DNP project. And she modified the model into what is called the EAT protocol, Encourage, Assess, Transition. So again, it's another variation of what Taryn did with her work. But I think what's important is that it shows us, even though that I started this model 20 years ago, this work needs to be continued. It needs to happen every day in our clinical practices. Next slide. I think the rest are just our references.
That's correct. Yep.
Perfect.
Here are our references and then instructions on how to get your nursing contact hours.
Thank you, Taryn and Dr. Spatz, for that presentation. I always learn new things during these webinars, and that was true again today. It looks like we are almost at the top of the hour, so I'm going to squeeze in a quick question, and then is it possible for me to send you the questions that came in that we can't get to? So
Absolutely.
I can provide answers? Okay, I will do that definitely, because we do have a list of them and they're all great. So quick question before we end. This one says, do you continue to do pre-post weights with all feedings, or do you move to algorithm?
So the goal, if you're on a scheduled amount, of human milk to be administered is to do a pre and post weight scale so that you know how much additional milk needs to be given. Once the baby transitions over to PO ad lib feeding, we don't necessarily continue to do the pre and post weights, or if we have enough data to say that the baby is successful at transferring milk at the breast, we tend to scale back on how many pre and post weights that we do.
Perfect, thank you. And it does look like we are at the top of the hour, so I will be sending the questions that came through to both of you to answer, and I will give them to everyone after this. And just a couple quick things before we end. You can visit medilaeducation.com to view and register for the upcoming webinars that we have planned out to the end of the year. And we sent out an eCamp today announcing our new e-learning courses that are available to put onto facility learning management systems for our customers. And for more information, you can reach out to your sales rep for that. And these are all supporting the initiation standard of care. And one last thing before we close, an evaluation will open up in a separate screen, and we would encourage you to fill that out so we can get feedback. And everyone, enjoy the rest of your day, and thank you again for joining us today.